All right, everyone. Thank you so much for joining us tonight. My name is Joe Matessa, and I'm a representative of Boston Scientific. I'm here tonight with Dr. Paurush Babbar of the Urology Group in Cincinnati. And I got to tell you, tonight's session is something that is deeply personal for me because I'm not only a representative of Boston Scientific, I'm also a prostate cancer survivor. So I am 8 years cancer-free, and I have been on your journey, and I commend you all for taking this step to figuring out how to live with life after prostate cancer. So with that, I am going to turn it over to Dr. Babbar. You'll see that there is a chat. If you'd like, you can send questions directly to the panelists, or you can select the option of panelists and attendees. At the conclusion of Dr. Babbar's presentation, I'll share a little bit about my journey, and then we'll jump right into the question and answers.
Thanks, Joe. So my name's Dr. Paurush Babbar. I'm with the Urology Group here in Cincinnati. So a little bit about myself. So I grew up in Melbourne, Australia, and I moved to the States for high school. And I was in Atlanta in high school, and then I went to undergrad in medical school at Wake Forest in North Carolina. And then I was lucky enough to be taken on by, I think, what is the preeminent urological institution in the world at the Cleveland Clinic for my residency. And that was a great experience there over 6 years. You know, we had a breadth of experience from kidney transplantation to female urology, stones, cancer, prostate cancer, prostatectomies. And then what always, though, drew me in throughout my training from an early stage was men's health, sexual medicine, reconstructive urology, and these type of issues of prostate cancer survivorship. And so I was lucky to be taken on as a fellow there under the tutelage of Dr. Ken Angermeyer and Hadley Wood, who are exceptional mentors and have taught me some of the tips and tricks throughout their career that they've learned at the clinic, and then some new developments on how to help prostate cancer survivors with quality of life issues, essentially after what is a life-changing diagnosis. So, these are some of my specialties, and I see patients at Eastgate and Norwood, and we'll happy to see anyone who wants to see us. So, so today's talk will focus on prostate cancer survivorship and some of the issues that can happen after treatment for prostate cancer. So the first thing I like to talk about is that when everyone who's listening tonight got their diagnosis of prostate cancer, it was a life-changing diagnosis. It was something that no one wants to hear, that C word. And then you're left at that point with a decision, right? So your urologist, your medical oncologist, radiation oncologist they laid out to you, okay, you have surgery, you can do radiation, you can do hormonal therapy, and then you and your doctors got together and made a decision that, okay, we will go with surgery, let's say. Now, what has happened since, potentially, and we'll go into, there's erectile dysfunction, there can be leakage of urine, low testosterone. These things are things that at that time, we were just thinking about, oh, we got to get the cancer under control. And it's great that, people are listening to this webinar today, because that means that likely the cancer control part was, from by and large successful, but then other side effects that are here, that we have to deal with. But I think that psychologically, sometimes patients that I see get, that they're hard on themselves. They say, I wish, I went for surgery, I should have done radiation, or vice versa. But you have to realize that you made that decision at the time with the best information you had, with some great physicians, and that was at that time the best decision that you could have made. And then, yes, hindsight is always 20/20, but so what some patients I see after prostate removal have some issues that patients with radiation don't, but then they have other issues and they would, so the grass always may seem greener on the other side, but you just have to mentally free yourself from that burden that, oh, I made the wrong decision. No, you made the right decision with the information you had at that time. So now we move forward, we get to these things that we're going to talk about. And I think we have some good solutions for a lot of these problems. And we're going to really deep dive into that today. So prostate cancer, as everyone will know, is the most common non-skin cancer in the United States. Nearly 1 in 9 men is affected by this. And today, there are nearly 3 million men in the US who count themselves as survivors, which is a great thing that we have such good treatment options to prolong survival. But now it's on, urologists such as myself who are fellowship trained in issues such as prostate cancer survivorship to educate the public on how we can help your quality of life now that you're on the other side of this life-changing diagnosis. So some side effects that we're going to really go into today are urinary incontinence, bladder leakage, erectile dysfunction, and then I may also just touch upon things such as low testosterone, urethral stricture, urethral narrowing that we can see after prostate cancer treatment, and then just even the psychological effects that prostate cancer can have after everything's said and done. So let's first go into the incontinence aspect of things. So after prostate cancer treatment, the bladder may leak a few drops of urine, or it may be an uncontrolled stream. This leakage generally tapers off within several weeks to months, but most patients would regain bladder control within a year. So if you have good continence prior and this is most likely, this part of the equation relates to prostate removal, so to surgery, then within a year, if you had good continence before surgery, generally most patients will have it after. But once in a while, some of the data will say maybe 7 to 10% of patients may have persistent urinary leakage or stress incontinence that can affect their daily life. So stress incontinence is a pattern of incontinence where if you cough, you sneeze, you lift something heavy, that increase in intra-abdominal pressure, it pushes down on the bladder. And what the prostate generally had the continence muscles, which kept it closed at baseline, that when you wanted to pee, it would open and the channel would be open. When the prostate's gone, in that 7 to 10% of patients who get this issue persistently, that urethra is open and then they may leak to varying degrees. So that's where we stand on this. So yeah, like I was saying, one study found that at 1 year following robotic prostatectomy, approximately 1 in 10 still may have persistent stress urinary incontinence. And then we have some good options for this. So if for mild leakage, I think the patients will generally go towards this just, to stay socially continent. So the pads, there are diapers for patients who are a little more incontinent. There's catheter collection devices like condom catheters that you can put on. Penile clamps, such as this one in the bottom left here, which is the Cunningham clamp, which essentially just constricts the urethra down. And then pelvic floor physical therapy or biofeedback that we can send patients to before and after prostate removal sometimes. And then Kegel exercise, which a lot of people have heard of, which essentially are a way of strengthening the pelvic floor. And for cases of mild leakage, they can help to make it more controllable so patients can avoid surgical procedures like we'll go into. But I think that generally, at the point that patients are using, probably 2 pads a day or more, and it's an impediment to their quality of life, then we have some good options. And I think it's important that we disseminate this information that we can do something, because at times I think when patients see their prostate urologist to remove the prostate, the crux of the discussion is on what's the PSA, how do we, there's no recurrence of the cancer, there's no metastatic disease, and that those issues are very important to survival. I would never refute that, but I think that sometimes this is not discussed with patients, or they're embarrassed to bring it up, which they shouldn't be, because it's common that this can happen after surgery. And this is not a indictment on the patient. This is not an indictment on the surgeon. I mean, this is just things can happen. The patient had cancer, and this is sometimes a side effect of the treatment. So for moderate leakage, injections or bulking agents, I don't think I really do much of those. I mean, those are an option. I think people used to do them more. The data behind it is not as robust anymore. So I'm not even really going to go into that much. Now, the male sling is an interesting solution for, I think, in my eyes, it's patients who have low volume leakage. So I'd characterize it as 1 to 2 pads per day and have not had radiation. Now, the data is emerging that maybe in radiated patients, you could still do it, but the first few studies that I've seen, the outcomes can be suboptimal at times. So the way the male sling works is it essentially is a hammock underneath the urethra, and it's intended to support it so that it can prevent leakage during coughing, sneezing, laughing, lifting, things of that nature. And the good part about this is right after the surgery, most patients are continent right away. Now, a few things are that you want to, we would give you instructions. You don't want to lift anything heavy for the first 6 weeks, because essentially we tighten the sling, and we in a certain way that you don't want to loosen it. Now, there is a new iteration of the sling, which you can see if you look here. There's these little barbs on it. This is a new thing, the Advance XP sling that came out about a year or two ago. Before, it did not have this, so I think it used to loosen a lot more. So this has been a very good technical advancement from Boston Scientific that makes it so that it helps to keep the tension. But still, if people right after surgery, because it is an outpatient surgery, we get you home the same day. If you go start lifting, crazy heavy things, then it can still, loosen it here and there. So that's something we want to be careful about. But I think it's a great solution in well-selected patients. So then, for patients who have more high volume, so moderate to severe stress urinary incontinence, so I would characterize this as, probably 3, 4, 5 pads. And I've seen patients who are continuously incontinent, 12, 15 pads a day. I mean, it is just so debilitating to one's quality of life. Then I think the artificial urinary sphincter is likely the best option to get someone dry. So essentially with this, there are 3 components. So there's a pump in the scrotum. There's a cuff around the urethra that you can see here. So essentially the urethra goes through, we put the cuff around it, and it's closed at baseline, essentially like your prostate was. And then when a patient wants to pee, the bladder fills up, you get that urge from your bladder, it goes to the brain, and you press this pump, this control pump that's in the scrotum, and it's just like 2 squeezes. And what that does is it opens the cuff. So the cuff has fluid, it pushes that fluid into this reservoir here, this pressure regulating balloon, and then essentially it opens for about 45 to 60 seconds on its own, and then on its own it will close off, and then you're good to go. So that's how it works. It is an outpatient surgery, generally speaking. I'm sending most of my patients home the same day. When I was trading in Cleveland, we would keep patients overnight, but I found that generally speaking, in most cases, barring any significant medical comorbidities, we can send patients safely home, and we've had no issues with that. And then now one big difference between this and the sling is for the first 6 weeks after this surgery, we don't activate the device, meaning that the cuff is open and you will still leak as much as you did preoperatively, because we want all the, it's a lot of fine suturing and things in there, and there's going to be some inflammation from dissecting around the urethra. So we don't want to immediately activate the device. So you'll leak the same amount as you did before surgery, but at 6 weeks you come in and I just manipulate the pump a little bit, and then boom, the device is active and you walk out of the clinic continent. So generally speaking, it works really well. So here is just a little video about it. So as you can see here, there's the pump that's in the scrotum, and I generally also place it on one side or the other, of one of the testicles, generally on the left side. And then as you can see, there's the cuff that's around the urethra. And when you press that, it opens up the cuff and you're able to pee, and then on its own, it closes back down. So pretty slick device that can help really. I mean, I think this is probably my favorite surgery out of any I do, because just seeing patients before surgery and then what they are, once we activate the device is night and day. I mean, guys who can't leave their house because they have infections down there from, fungal dermatitis. It smells and they're just embarrassed. They can't go to the pool and things like that. They're back playing golf, and just it gives you a new lease on life. It's so powerful, this procedure. So and it's one thing, and it's not that if this is not done right away, you have to have it done. So I just saw a patient who had his prostate removed 8 years ago, and he's just been leaking, I think it was 5 to 6 pads a day. And we just activated him in the office this week, and he's continent and just happy as can be. So even if your prostate cancer procedure was years ago, that we can still generally work around it and go from there. So just to assess your condition, just fixincontinence.com has some more information that can go into this. And just one other thing I would talk about with the sphincter. So people ask, well, what side effects when I talk to patients in the clinic? Just like any implant in the body, any artificial knee, artificial hip, heart valve, there's a risk of infection. So there's a risk of infection with an artificial sphincter as well, generally 1 to 2.5% risk, and then a little higher in diabetics. But we do a lot of things to help decrease that risk. We check urine samples before surgery. We give a week of antibiotics after. We give IV antibiotics at the time of surgery. We do a thorough scrubbing. So there's many things we do, and there's encoding on the device that helps decrease that risk. And then one other thing is, because this cuff is constantly holding on the urethra, we want to take care not to over tighten it, because then it can erode through the urethra. So that's one thing we look out for. And then just like, because there's fluid moving back and forth, there's a chance that that fluid that we fill that in the device can leak. And so if that happens, nothing life-threatening. Patients incontinent again, you just have to go and replace the device. So generally speaking, the risk of that at 5 years of that happening is about 19%. And then at 10 years, maybe it's about, so 66% are still working. So it'd be 34% chance that you have to replace the device at 10 years. So, it's just like a touch-up surgery that it just to replace the device. But all right, next topic, the restoration of sexual health. So commonly after prostate cancer treatment. So this applies, I think, even to both, patients who've had radiation, hormonal therapy, brachytherapy, prostate removal, where if they have to go wide and take some of the nerves, so then patients can have erectile dysfunction. So prostate cancer the treatment can affect the nerves that control erections. May take as long as 2 years or longer to regain sexual function. So this generally is after prostate removal. Now, with the radiation, what I've found, the pattern is that at first, patients for the first probably 2 years will be doing great, and all of a sudden you kind of fall off a hill if you're one of the patients who gets erectile issues. And it can a lot of times just be that the nerves are a little damaged that run on the side of the prostate from the radiation treatment. And generally, once that happens, it doesn't really like rebound that I've seen. So whereas with surgery, some of those side effects with erectile dysfunction you'll see up front, but then generally speaking, they get better over time in the majority of patients. But then once, sometimes there are patients who have persistent issues with erectile dysfunction. So penile rehabilitation following prostatectomy may help nerves responsible for erections recover after surgery. So some of the things that your prostatectomist might do, or if you come and see me, we can recommend we can start low dose Viagra or Cialis for a little while after surgery. You can start a vacuum erection device as soon as the catheter comes out. Now that has to be obviously approved by your prostatectomist, but there are some emerging studies that this can help out of UCLA. So I think that these are good things to consider. So treatment options for erectile dysfunction. So oral medications, these can be offered before or after prostate cancer treatment. Then there's vacuum pump erection devices. So essentially this is like a hollow tube that sucks blood into the penis, and then you use a constricting band at the base of the penis, as you can see in this top right image, and then that keeps the blood there, and that can increase blood flow to the penis. Then if both these treatments, let's say, are not working, or we need to kick it up, then we go to sometimes penile injections. So these are injections that are put directly into the penis. And they have a small amount of drug in them that increases blood flow to the penis. And as opposed to these Viagra and Cialis, which you have to take by mouth and you can get some systemic side effects because it's an oral pill that goes throughout the body. This is a very local effect and actually works quite well. So you take it 5 to 20 minutes before intercourse, and then the 60 to 80% patient and partner satisfaction with penile injections generally. So I think it is a good therapy, and can definitely help in certain cases. Urethral suppositories, I'm not going to go into. I don't really think they work that well, and there's some side effects with urethral stricture disease. So we won't even talk about that. One treatment that I do want to bring up is penile shockwave. So this is kind of the new boy on the block, I would say. So this is essentially, we've been doing shockwave for kidney stones for years, since the mid 80s. Now, so in about 10 years ago or so in Europe and Israel, some groups started investigating, could you use a different type of shockwave, but essentially ultrasonic waves to penetrate the penis and then cause some local nerve regeneration, stem cell proliferation, and increased blood flow to the penis. And so the data, there's essentially two types of shockwave, and our group has finally, after 2 years of really looking into the data, has invested in a focal shockwave, which I think is the one that has all the randomized clinical trials. And in certain patients who I think respond to sildenafil, Viagra, Cialis, but just need a little bit of an extra boost, I think that shockwave is a good option. But look, if a patient, you take Viagra and you get no response, I think that trying shockwave is, I don't think it's probably going to help. But so it's something that we are offering at the urology group, and I think we're the only group in town that we offer the focal shockwave, because all the other places, the Gainesway, things like that, are radial shockwave. So there's really no data. There's no randomized controlled trials behind that. That can be operated by anyone, whereas the focal shockwave has to be a urologist. So we stand behind that, and I think that something that we can talk about if you come in to see us. Lastly, penile implants. So in patients who have tried a lot of these treatments and have failed, or for instance, they don't want to do injections into their penis, there's penile implants. So this is a 3-piece device similar to the sphincter in a way that it has 3 components. There's a pump in the scrotum. There's 2 cylinders that sit in the 2 erection chambers of the penis, and then there's a reservoir fluid we tuck in the abdomen. And so essentially, when you want to have intercourse, you pump the device and it sucks the fluid from the reservoir into the cylinders, and you're good to go. And then there's a little deflation button you press at the end, and then the fluid goes back down and you go to the flaccid state. So this shows what I was just talking about. So in the scrotum, there's this pump. Then in the penis, there's 2 cylinders, and then we tuck the reservoir into the abdomen. So it feels natural during intercourse. I think one of the great things with the penile implant is offers spontaneity. So with the pills, for instance, you have to wait a certain amount of time. With the injections, you have to go draw up the medicine, then also wait. Whereas with this, once you're facile at it, takes our patients 20 to 30 seconds, you're ready to go. So that's really good. It's completely concealed. So all this is on the inside. Nothing is visible, to your partner, which is good. You can be in a locker room. No one is going to know you have one of these, and they maintain an erection as long as you desire. You can use it as many times in a day. So here's how it works in animation. So here the animation showing that when you press the pump in the scrotum, it pulls the fluid from that reservoir into the 2 cylinders in the penis. Get a nice rigid erection. The reservoir is deflated. You don't feel that. That's tucked deep in the abdomen. And then when you're done, there's a little deflation check valve that you press, and that fluid goes back from the cylinders into the reservoir. So it's a good option because it really mimics what the penis physiology is, that it's flaccid, and then when you want to have sex, it's erect. So now there's another type of penile implant which is essentially these semi-rigid rods that you can put in. So if someone like doesn't have good hand dexterity, they have Parkinson's or something, or they just don't want to mess around with fluid moving back and forth because there is a risk of device malfunction, then you can just pop in these semi-rigid rods, and that can help too. So here we go. This is a real patient demonstration of this gentleman using his penile implant. Okay. So here we go. And the patient's going to deflate his device now. So you can feel the deflation valve. It's a little like groove you can feel on the pump, and then he just presses that, and the implant goes down. Sometimes you can actually like choke on the penis, and it goes down a little faster, but it's and then it conceals really well, which is critical too. So very good. So just like with the fixincontinence.com, so there's edcure.org, which is where you can assess your condition and take a look at some more information about erectile dysfunction and some of the various cures, and things of that nature. So one other thing corollary with erectile dysfunction I want to bring up is low testosterone. So I think that sometimes patients will see after prostate cancer treatment, especially patients who may have had hormonal therapy, that their libido is gone, right? So as long as the prostate cancer is totally under control and undetectable, then if then we would check testosterone. If it looks like it's extremely low, and that may be a cause of just like not feeling very fatigued, having increased weight gain, decreased muscle mass, low libido, erectile dysfunction. Sometimes it's important to consider doing testosterone replacement. I'm not saying that someone who gets their prostate removed is gonna that causes low testosterone, but sometimes you're in this age group, right, where that hypogonadism or low testosterone goes there. So I always take, we would take a history and make sure that that's not another thing that could be exacerbating things. Because the last thing we need to do is, we put this penile implant in, but you have no desire to have sex, right? So that's something to look into. Another thing that I always think about with prostate cancer survivorship. Okay, so these are other issues that patients can have. So urethral stricture disease. So meaning sometimes after both radiation or prostate cancer removal, the urethra tube can get narrow, right? So let's say when your prostate's removed, they sew the bladder to the urethra. If that area scars down, that can be a big problem. And that's something where the urine stream, you're not able to pee. So we would have to look into that, and essentially we have to open it up or do a big reconstruction to essentially put that back together. Or even with radiation treatment, that is something like if you're unable to pee, that we have to do a urethroplasty sometimes. And so then the last thing which is I mean it's in the scope of this talk, but I think that this when we talk about this, we get help from some of our colleagues in other fields of medicine. So once you have prostate cancer and you come through the other side, psychologically, it can be a big, taxing thing on one's mind, because, you may feel like, some patients tell me they feel like less of a man, they're leaking, they can't, have good erections. And so, we can help treat that. But I think it's very important. I like to get patients plugged in with our some psychology and psychiatric colleagues, and I have a good sex therapist we work with, and I think those parts of the picture are very important in prostate cancer survivorship. Like, I can help you anatomically, and we can talk through certain things, but we have to also really look at men as a whole, and work on the psyche as well. So it's very important to really get into that with your urologist as well. So just a few frequently asked questions. How long does it take to achieve bladder control? So like we talked about, incontinence usually will resolve within a year following prostatectomy, but in some cases it can persist. And that if it does persist, I think that it likely at that point is not, going to, like if you're leaking 1 pad a day, maybe, it could get better. But if you're leaking like 6, 7 pads a day, it's not going to, in my eyes, get better so that it's going to be 0. No, I think you're going to likely need some type of intervention if that is an important part of your life that you want to regain. And there's no shame in that. I encourage you to come in and see me, and we take care of that. We have 4 of these upcoming in 2 weeks from now. A lot of patients we're doing it for and helping in the Cincinnati area, and I think it's a great thing to help with incontinence. So why don't all men recover erectile function after treatment? So your ability to have an erection after prostatectomy, there's pre-existing conditions. If you have older age, heart disease, diabetes, smoking, inactivity, obesity, so things like that. So, and it also just depends on what treatment modality you had, like if which type of radiation, proton therapy, was it a high dose radiation? Did you have hormonal therapy in addition? So there's a lot of things that play into that we would have to review in the office. And then, great question is like, are penile implants, or for that matter, artificial sphincters or slings covered by insurance? And so most insurances will cover the diagnosis just because it is under this prostate cancer survivorship umbrella. But, we would work with you to see, what we can do and take it from there. So these are just some real patients who have had some good results. And this patient Roy talks about, after 7 years with the male sling, I still find pads in a suitcase or a jacket that I haven't worn. It would be hidden in the pocket somewhere. I laugh and think, thank goodness I don't wear these anymore. Yeah, absolutely. And then prostate cancer surgery left me both incontinent and with erectile dysfunction. After having the AUS, I could go places again and do things socially without risk and embarrassment. Now that I don't have the incontinence problem anymore, I was ready to deal with ED. When I had the penile implant, I felt completely whole again. It restored my confidence and restored my life. That's powerful, absolutely. And I hear that not uncommonly, which is great. So here's some resources that people can go to for more information. So just in summation, so erectile restoration, it's a very common problem. Even patients who don't have prostate cancer issues, but especially in this population, and penile implants can offer a permanent long-term solution. But I think it's important to come see us because, maybe you need another option, and we offer the full spectrum. And I think that's the key, that we will, we offer, we can go into what's tailored for your situation. And then urinary control, you stress urinary incontinence. Incontinence after prostate cancer treatment can be effectively managed. If it lasts more than a year, I think it's time to come in and see someone and not, live in silence, because I think this is something we can definitely help.
Okay, thank you, Dr. Babbar. So I'd like to take a few minutes now and just share my journey, a journey that probably sounds a lot like many of yours. I was diagnosed with prostate cancer 8 years ago when I was 43 years old. And as you can imagine, at that age, it was a pretty devastating diagnosis to hear. And my kids, I have twin boys that were 4 years old at the time, and it was advanced. And within 2 weeks, they had me in to do the radical prostatectomy because I was not a candidate for the pellets, because my kids were so young, and having them around me, I couldn't have those pellets in me. And I was not a candidate for radiation because once you've been radiated, you can't go back and radiate if the cancer comes back. So I was told that I had to have the prostatectomy just in case down the road the cancer would come back again. And so I had my surgery, and I met with the surgeon, and He told me that it was nerve sparing and that I should gain full functionality with my erections and my continence, and all would be good. And so I went back and did everything I was told to do. And I felt like in the beginning, I had some erections. I did not experience the incontinence in the long term. I did for about 3 months. I was wearing a pad. And then after those 3 months, I was fine. But the erections, I felt like the pills worked early on, but did not maintain the erection. And over time, they lost their effectiveness. So I would say it was a year or so after I realized that the pills weren't working for me anymore, that I felt like I needed to look at other options. And my primary care physician is the one that was prescribing the pills for me. And so he didn't really have any other options that he could help me with. So I went out on my own and I found another urologist, and that urologist only wanted to try me on the injections. And so I did the injections for about 3 months, and they worked with moderate success. There were some side effects that I didn't care for. One is I felt like there was a dull achiness in my penis, and the serum for the injections has to be frozen or refrigerated. And so it wasn't very portable. And so you had to be home and you had to prepare, as Dr. Babbar mentioned, and it was a process. I tried the vacuum device, and that wasn't something that I liked doing either, simply because it doesn't really have that spontaneity, and didn't like the feeling of the clamp. And so at that point, I felt like I didn't have any other options. So I went to a clinic, a local men's clinic, and they just wanted to give me pills and injections, and it was at a very high cost. It was not covered by insurance, and I gave them money out of desperation, and realized that they couldn't do anything for me that the urologist was recommending. And so that's when I truly felt like I had lost all hope. And at that point in time, I started falling into a depression. My marriage fell apart, and I really didn't know where to go. 6 years after my diagnosis, I attended one of these webinars and learned about my options for a penile implant. And I was connected to a prostatic urologist on edcure.org and had my implant put in 2 years ago. And I can honestly say it was completely life-changing for me. I felt whole again. I felt like a man again. And I felt like I could get back to life as it was before my surgery. And that just opened up all new doors to me. I was dating again, and I'm engaged to be married in August. So it has a happy ending. And so I really can't stress enough how much it affected me psychologically, emotionally, and physically. And it is completely concealed. So no one ever knows that I have anything, whether I'm in the locker room or in the bedroom. It is completely concealed. And even the pump that's in the scrotum can be a part of foreplay if you'd like. I mean, if your partner's game, you can just work it right in.